Welcome. Well, thanks so much all for joining us here on this webinar today. I want to make sure that everyone, we have folks joining. We're going to have everyone on mute when you're joining. So just wanted to let you know that if you want to come off mute during a point where we're asking questions or inviting you to ask questions, you can do so by pressing *6 on your phone or pressing the little microphone icon, which you'll either see next to your name in the participant list or also at the bottom of your screen to unmute yourself. So if you're hearing me speaking, then you're already connected to audio. Hopefully others can take a look and see on the screen if they're not connected yet to audio. And then just want to make sure that you activate your chat. So as you see on the instructions here in step 2, press that little blue button that looks like a little speech bubble at the bottom. That will open your chat panel on the right. And from there, you can select if you want to send a message to everyone in the group or to anyone in particular, including the host, Jen Yang, if you're having any technical difficulties. So you can go ahead and do that. If you can think, please put yourself on mute if you're not on it already. We have 3 faculty members here. I'm going to turn it over to Ellen to introduce everyone.
Okay, great. Thanks, Janice. And hi, everybody. My name's Ellen Lawton. I'm at the National Center for Medical Legal Partnership. So excited to be with you today and really looking forward to the work that we're going to do together in this 4-week sprint that kicks off today. And thanks to Janice Ikeda, who has been the heartbeat of the work behind the scenes, and you've all been hearing from Janice in your inbox, and really is a font of wisdom for a lot of the different dynamics that we're needing to put in place in order to connect with you and to share some of these insights and learnings. And so very, very fortunate to be here as part of the Social Determinants of Health Academy. For those of you who aren't familiar, it's a HRSA-funded cross-NCA initiative that is really seeking to unify the expertise of national cooperative agreements and generate both resources, peer technical assistance, and learning opportunities like this one to move us ahead towards more effective work on a daily basis focused on the social determinants of health. And so very fortunate to be able to have the faculty that we have today. So, and you'll hear from them, Marcella McGuire from Corporation for Supportive Housing, and Marcella is going to lead into our speaker panels, and Michelle Jester from NAC. And so just to give you a couple of warm-ups here in terms of logistics, and our contact information should anything come up. And then just a reminder of the Learning Collaborative Series goals. We have a total of 4 sessions, and I'm just going to actually read aloud to you in an adult learning mode here because you've gotten the abstracts, you've reviewed them, I'm sure, carefully. Our learning objectives today, our first learning objective is to get oriented to learning collaborative peers, logistics, expectations, and resources. And so we're going to do some of that, obviously, right now. And you've all had the opportunity, your participant lists, so take a peek at that and see who is sitting in the classroom next to you. You have the opportunity to hop on Slack, and Janice will talk with you about that. And we're going to be pinging you with additional resources. And so we'll be getting to know each other over the next couple of weeks. Our second learning objective, and again, Marcella is going to open it up, is to deepen understanding of current Medicaid SDOH landscape, guided by our expert faculty from CHCS, and also our session discussions from Michigan and the Missouri Primary Care Association. And so, and the third learning objective is sharing insights and questions about models in our local communities and how they're being developed and sustained over time. And so Michigan and Missouri, so grateful that they're joining us, but really this is also about you and the work that you're doing, and some of you are just getting started, and some of you have been doing this work for a while and are looking to break in some new ideas and strategies, and so we want to help you do that. And in order to do that, we want you to step into the middle of the circle during this learning collaborative. So, so those are my sort of opening gambit there. Next slide. Let us know how many people are out there in internet land. How many people from your team are joining us for this experience? Where does the poll pop up? Can't
it should be popping up on the right side of your screen.
Okay. Oh, there we go. People can just let us know. Are you calling in solo, or have you got a team of people around you? And that would be helpful for us to know, and submit your response. Can we move from the slide?
So please make sure you select the response that you want and then hit submit at the bottom right.
Great. Okay, and that will show, will that show up even if we move off the slide? Give people a minute to submit their questions.
Okay. And Jen has a hold of the slides now. Okay, there we go.
Great, so how to participate, webinars via WebEx, obviously. Slack, and I'm going to be learning right alongside you. It's new for me. I know it isn't for some of you, but it's a great opportunity to break in a new learning platform and connect with each other. And so I just encourage you to hop in there, maybe upload a resource or something just to experiment. There are no penalties for making a mistake on Slack. And expectations and rules of order. Next slide. We are really looking for full participation. Okay, great. Now I'm just looking here at the results of our poll. And so I'm having a hard time reading that. Bar graph. Okay, we've got, it looks like we're pretty split. We've got about half of the audience is flying solo. So you're really going to want to connect with folks virtually. And then we've got some people who are on a duet there. And then we've got a group that are in 3 or more. If I'm reading it accurately. So we're looking for full participation, obviously, and respect of varying opinions and experiences, and to really hopefully take on the post-webinar opportunities that you're going to have around homework, engaging with each other on Slack, certainly contacting us offline in any platform you want. And if you can make those commitments, then we're going to be happy to give you a certificate of completion at the end. Next slide. Oh, that's Janice. Janice, take it away.
Yep, so we're going to be doing webinars via WebEx. So what you're on right now, this is the main driver of our learning collaborative, but we also have some fun other features that we'll talk about now. So Slack, thanks so much to everyone who has already joined. I sent the instructions and the link to join in a couple of the different homework sort of update emails that I sent out. If for some reason you're having any trouble with it or need the links or the packet again, just email me. The slides for today are currently posted in Slack under the Session 1 channel that you'll see along the left there. So we'll email them out next week, but if you want to see them before, go ahead and log into Slack, and then you can get access to those slides as well as other important information. And there's a section in peer-to-peer discussion for you to just chat with other people, ask questions, share resources, so lots to explore. You can see more in that how-to guide that I included in your welcome packet, and contact me with any questions.
Great. So go ahead.
Oh, one other poll that's going to be coming up on the right side of your screen. And I know we had some folks who didn't jump in and click on that last one. We want to make sure that everyone participates in this poll so we have a good sense of who's in the room.
Great. Thanks, Janice. And I'll just say, this is Ellen again, before we kick it over to Marcella. And as folks are filling out the poll, you know, we're all learning together in this brand new dynamic landscape, myself included. And so I think that that's a really important reminder that I don't think anybody has cracked this. We have different levels of expertise on different topics. And so we're really hoping that we can do a lot of sharing and building each other's confidence as well as each other's skill set. So please take a moment and pick A, B, or C, and we'll give it a second while I hand it over to Marcella. Marcella, you want to take it away?
Absolutely. All right. Thanks so much, Ellen. And thanks, everybody, for joining us today. We're excited to have you a part of this and, you know, excited to have the conversation. Absolutely, 210% agree with what Ellen said, that there is no absolute expert. There is no absolute answers. This is an evolving field, and we can all learn from each other, engage from each other. As I said, my name is Marcella McGuire. I'm one of your core faculty for the Learning Collaborative, along with Ellen and Michelle and Janice. We all know that health centers are deeply engaged in social determinants of health work. We're going to hear from numerous examples during our month together, both from you all as well as from our presenters. And we hope you can share many of those examples and both the successes you have, but also the challenges, the bumps in the road that you've hit. And if you can share them both in our Learning Collaborative dialogue here or also on the Slack channel. We all know that health centers' missions clearly and closely align with impacting social determinants. Health centers' history, you know, was born of the necessity of addressing social determinants long before that, you know, particularly buzzy phrase was born. And we also know that fiscal sustainability is likely the biggest barrier to develop or scaling your social determinants of health activities that you're working on at your health centers, you're thinking about at your health centers. So that fiscal sustainability will be much of the focus in our dialogue over the next month. As our previous folks said, we're all experts here. We all have something to teach. We all have something to learn. And just want to highlight that I'm also, technology challenged sometimes, but excited to see what I can figure out how to do on Slack and learn how to better connect and support you and learn things as well on Slack. So want to highlight that channel there. The initial homework that you hopefully were able to get a chance to review, the CHCS report on how states and Medicare managed plans are investing in activities. While there's widespread agreement about the impact on health outcomes and costs for social determinants of health activities, as I'm sure many of you have found, commonly you hit what we like to call the wrong pocket problem when you're trying to make investments in social determinants. The wrong pocket problem, simply stated, is that if I save money on healthcare costs, for example, by investing in housing, I've saved healthcare money, but I've cost housing money. Healthcare and housing are different pockets in every state, different line items in state, federal, and local budgets. Interventions may save state funds in one place, but they may cost federal funds in another. These non-aligned incentives create difficulties for different pockets, and it creates incentives for pockets to save, but it also creates strong disincentives for pockets that have to spend without a direct investment or return to their pocket. So that's really some of the frame that we're looking at and how to encourage stakeholders to have a much more broader look than that, have a really true whole person care perspective, but I'm sure all of you know what a challenge that can be. It's important to remember this is an evolving space. The webinar highlighted, it's going to highlight that most contract agreements are Common contract requirements are screening and referrals for social determinants of health. As more plans better understand the research challenges in the field, we hope that many of those plans will begin to learn that how referrals can't lead to services due to lack of capacity. We hope this will encourage investment from the states and plans. And as states and plans gather the data needed to cost out potential interventions, this will allow states and plans to make informed decisions regarding where and how to invest in interventions that have the greatest potential for impact. Our team can't emphasize enough the need for centers to capture actionable data that clearly documents the return on investment case for state health plans. Our speakers in the series will share their examples of implementing interventions, how those projects are started, what federal, state, and local policy environment facts supported that activity, and some real concrete strategies for your health center or PCA to begin influence the policy environment to support your health center's work. We recognize that each state is different. A few of our participants are in primarily rural or frontier states. We have some participants from states without managed care. And just know that anytime we talk about influencing the state and the health plan, for those of you in non-managed care environments, we're really just talking about the state. But everyone active in this area is looking at clearly defining and building a locally relevant business case for your social determinants of health activities. And with that, I'm excited to turn it over to our speakers, Deborah and Jim from the Center for Healthcare Strategies. Deborah, Jim, here you go.
Thanks, Marcella. Hi, everyone. I just first want to thank Ellen, Michelle, and Marcella just for inviting us to speak today. We're really excited to be part of this Learning Collaborative session and hope you find the information we share helpful, and we'll acknowledge that we too are learning as we go. So happy to be learning alongside you all. And for those of you who are not familiar with our organization, the Center for Healthcare Strategies, or CHCS, is a nonprofit health policy resource center, and we work nationally with states, with providers, with plans on designing and implementing programs that improve access and quality of care, particularly for vulnerable populations. So we have a strong focus on Medicaid funded work. And we've recently been more heavily involved in a whole portfolio of projects related to social determinants of health, given the focus. And so we're really excited to share some of our learnings, but we also encourage you to check out our website for more resources that we likely won't be able to touch on all of them in the limited time we have today. So with that, just briefly, as far as the agenda, although ambitious, and we'll encourage you all to stay on for Q&A and recognize that many of your questions may relate to more of the implementation operational considerations around this work. But this presentation is really meant to provide a quick snapshot of some of the federal and state policies and activities that can potentially be tapped into to further your all's work at the provider level. And we do want to touch on some of the opportunities to partner with health plans, recognizing that this may not be applicable for all of you, but certainly is a trend among those where managed care is in place in terms of partnership opportunities to further support these social determinants of health interventions. So just briefly, and some of this is kind of repetitive of what Marcella already noted, but as you likely all well know, there's been a growing focus on social determinants of health as a means to really better manage Medicaid populations. And so some of what's also driving this work is related to the financial incentives that states are putting in place around value-based payment. And so sort of contextualizing some of the social determinants of health specific work within the broader care delivery and payment reform efforts going on, as well as some of the federal regulations and policies that support states and give them more recently opportunities to test out their own approaches at the state level to better address these social needs. And we're seeing a lot of that in the work that we do that is state-facing. So just quickly, some of the key sort of federal regulatory notes that we just wanted to make reference to that we think, present some opportunities for enhancing social determinants of health activities at the state and also at the community and provider level. And those include, again, this probably isn't news to you, but just framing up the discussion again, the 2016 Medicaid managed care regulations that essentially clarified what social determinants of health activities Medicaid managed care plans can pay for, and considering some of the broader financial implications for the plans, and also, where they have flexibility to really manage how those services are supported and where they partner with providers to do so. Naturally, the other piece is, one of the other major pieces is around the 1115 demonstrations or waivers, which essentially enable Medicaid to waive specific federal rules and present what we see as an opportunity for states to really test out models for increasing or enhancing social determinants of health activities. So just briefly, in terms of an overview of the slew of sort of Medicaid focused social determinants of health activities and levers, we refer to a broad range that fall under this social determinants of health umbrella. And as Marcella said, the range in terms of activities from screening to referrals and navigation supports, among other activities. And so some of the levers there at the state, community, local level that really drive action here are noted. But time permitting, we're going to explore some of these further, but are going to focus on the delivery system program requirements, the MCO contracts in particular, just given the focal point of our ACAP-funded report. So hopefully you all have had a chance to take a look. We know it's a dense report and there's a lot of information in there, so hopefully this presentation will help cut to the chase and give you a good sense of what our findings were. So in terms of the report that CHS pulled together with support and funding from the Association for Community Affiliated Plans, or ACAP, we focused on a review of the Medicaid managed care RFPs and contracts from 40 states and 25 1115 demonstrations, which include the DSRIP efforts in several states, and I know many of you are represented here today among states that are actively involved in DSRIP programs. So really the intent was to get a broad sense for what states are requiring of their health plans, of their providers around social determinants of health, and how they're using these vehicles to basically articulate those requirements. So just to sort of jump to what those key findings were, and we, specific to the managed care contracts, essentially our findings revolve around, one, sort of this notion that despite the range of requirements that states have for their Medicaid managed care plans, and also the range and specificity of those requirements, there remains a significant flexibility for these plans and therefore an opportunity in terms of how they and their partnering providers, including you all, can support those social determinants of health activities like screening and referrals. And we recognize that many of those activities are ones you are already supporting separate from those health plans, but recognizing that now the plans are required to support these activities more formally and have some flexibilities for how they can support those and pay for those. The other piece that's sort of part of the key findings noted here is really around that much of the contractual requirements that we found are really paired with some broader reform efforts, and in some cases, some value-based payment incentives to really help further activate these services. So essentially, this work, the contractual language is not happening in a vacuum, as you can understand. So it's, states are kind of framing the specific requirements for plans in the context of the other efforts going on within a state, whether it's their ACO program or some of their kind of DSRIP-related incentive payment work. And part of our report, as I said, focused on specifically the 1115 demonstrations. Although this may be somewhat less relevant for today's discussion, I just wanted to note that I think our findings reflect the importance for providers and other stakeholders to really have a seat at the table when these 1115 demonstrations and waivers are being discussed and designed. And I don't want to oversimplify the process to get to that table and be part of those conversations, but acknowledge, again, kind of the opportunity for providers to be part of that planning and design. So some specific state examples of the managed care contractual requirements that I mentioned are noted here. And these happen to be some of the states that we're watching particularly closely, given some of their innovative, and really kind of advanced approaches to embedding social determinants of health requirements and being specific about what those are. So I think the implications for providers vary naturally based on the variation in the approaches noted here and among some of the other states we profiled. But given that there are many variables, you can kind of see the range, though, of the approaches that are being explored, from simply requiring some basic screening to much more sophisticated sort of implementing a bonus fund or more specific contractual requirements for community-based organizations to be involved, let's say. Unfortunately, what makes this somewhat complex is really there is no universal, simple way to kind of track these efforts and have some general rules for, what states are doing and how providers can connect within their states, because it really does vary, and I think you all know that better than we do. But just acknowledging that, there's certainly opportunity for you all and providers to stay connected to what's happening at the state level, but recognizing that there is really a broad range of efforts going on. What we did want to spend some time discussing, and happy to also answer questions related to this, is really in light of the report findings, we thought it was worth mentioning some ways that, again, for those states where there is managed care, where the plans and providers are partnering to support this work. And as noted earlier, given the existing flexibilities for these plans, to play to their strengths, essentially, there's a range of approaches that are being explored, from supporting the social determinants of health services internally within a plan, which tends to be primarily telephonic, versus partnering with a range of providers. And some of this is already happening naturally, even previous to these newer contractual requirements, but really formalizing the relationships with health plans and providers to really carve out roles for each to support based on their strengths and based on the interests of each of the partners. So essentially what we've seen is sort of a build versus buy question, where the health plans and the providers are deciding between, what should be supported by each and what's worth kind of supporting internal to the plan and what makes sense to really lean heavily on a provider to support. So in terms of these partnerships, naturally, Medicaid managed care organizations are likely to prioritize efforts that align with their existing priorities and state contractual requirements, as I've noted, since these are things they have to do, and also with efforts that demonstrate a near-term ROI. And we recognize the challenges with that in the context of this type of work, where the return on investment tends to be longer than what a typical plan may be looking for, and doesn't necessarily acknowledge, the importance of the work. So, the shortcomings aside, just recognizing that this still is a way that plans think about this work. But I think what we're seeing is that there's a recognition that some of this work takes a while to develop a return, and so providers and plans are kind of considering various social determinants of health activities within a portfolio that includes some of these more short-term projects that can lead to some short-term gains versus some of these longer-term investments that really are going to take several years to produce what they, what agreed upon as the return on investment that they're looking for. So, but that certainly is an important area that is being explored from what we can tell in our work. I think the one other point to mention is really that health plans and providers seem to be coming to the table around activities that can be scaled over many providers and across geographies, because practically speaking, this is where agreements between plans and providers can be most fruitful. And so we're seeing providers obviously partner with one another and come together as a network that supports a spectrum of these services to really make it more of a value proposition that's clear for a health plan. So given all of this, also, we naturally tend to see these partnership examples really focused in on the high-need populations with frequent emergency room and inpatient admissions and utilization. Again, probably not at all a surprise to you, and you're living it every day, but just acknowledging that that is what we're seeing across the board, understandably so, given what some of the criteria that plans consider to be important in this work. So I've listed out some examples here related to key areas of interest, particularly opportunities where there is a significant room to reduce costs and improve quality of care, particularly care transitions, again, of no surprise to folks, I'm sure. What we thought might be helpful is just to walk through a specific example, and the intent is just to highlight how these partnerships have emerged, how community-based organizations and providers have come together and approached health plans in some cases, although we've seen the directionality of where these partnerships emerged also varied. So sometimes it's initiated by the community-based organization that's providing the social service. Sometimes it's at more of the medical, clinical level, and sometimes it's the health plan that comes to the provider network to ask that they support XYZ services. So we acknowledge there's certainly a range again, but thought that these were some interesting examples of how these partnerships are developing in a way that sort of is a win-win for all involved. So we thought we'd follow through the Project Access Now example, and some of you may be familiar with that out of Portland, Oregon. What we've laid out here is really just speaking to my earlier points around approaching a health plan, working with health plans, or if not managed care, then with the state, really to support the requirements that are laid out as far as social determinants are related. So in this case, this is an example with Oregon, which I know is not necessarily, it's sort of its own animal, but just to kind of give an illustration of how this trickles down from the state to the plan to the provider. These are some of the contractual requirements that we reviewed related to social determinants of health, and also listed are some of the quality improvement measures that are required of the CCOs, or the coordinated care organizations within Oregon. And this is all laid out in their 1115 waiver, and they have some clear requirements, as noted here, that really focus in on reducing admissions and utilization. So with that, the Project Access Now Community Assistance Program, which we focused on for a series of case studies that we can certainly share, essentially it operates as a hub for a network of social service providers and some clinical providers in the Portland area. And it's funded in part through Oregon's MCO-led coordinated care organizations, where in the CCOs, they basically outsource the function of transitioning recently hospitalized beneficiaries, connecting them with various services like transportation, like temporary housing and food supports through a voucher system that tracks all of the received services. So the hub of this provider network essentially approached the CCOs and the state as an established resource, a trusted community partner, which I imagine you all view yourselves as and have deep-rooted relationships in the community. And that was really the approach that they took in managing sort of the end-to-end from screening and service for these beneficiaries. And the program is focused really on ensuring safe discharges from the hospital and mitigating any challenges that might result in additional care or hospitalizations, rehospitalizations. So we just thought this was an interesting partnership because it is funded through the health plans, but it is directly lines up with what the state's requirements are of these CCOs. So it really points to the fact that we're all sort of moving in a similar direction and that there's a sustainable pathway for providers to be paid for some of these social determinants of health-related services. And so the Project Access Now partnership really supports frontline hospital staff, including discharge planners, social workers, care managers, to connect low-income patients to the resources I mentioned. And they work with over 100 vendors. They provide these patients with vouchers to really track the usage of those services and also follow through to see the impact on the discharge, on the hospitalizations and the utilization. There's some additional context to these partnerships that make them work, but I just wanted to focus in on the particular sort of partnership with the health plan piece and note that anecdotally there's evidence that this program is really cost effective and that the program has saved, I think, an estimated $2 million or so since its inception. So I think it just serves as a helpful example to illustrate the principles we noted earlier around, what a health plan is likely to prioritize, how providers present themselves, and what the value proposition is, outside of what, much of which, is evident already in the work that you do every day. But really in terms of focusing on helping to address strategic issues for health plans for the state, and really playing to the strengths of each of the partners. So I think we'll stop there and pause for some Q&A.
Great, thanks, Deborah, for a really cogent overview. And I think it makes sense. I don't see any questions in the chat box, but folks who did their homework submitted some questions. And so I think it makes sense to start with one of those questions. And then that'll give us a good transition over to our friends at Missouri and Michigan Primary Care. So do you want to pluck out a question and or do you want me to kick off question 8? I can read that out.
Sure.
Yeah, so we heard from you. So this is a question that came out of Texas, the Hope Clinic. With Medicaid gearing to invest in addressing SDOH, as we just heard, will they alter reimbursement guidelines? Currently for an FQHC, many services that can help address a patient's social determinants are not billable. What are the areas of impact to consider when addressing SDOH?
Yeah, thank you. So, and again, we probably have bits and pieces of this, so welcome others to chime in, and I'll also welcome my colleague Jim Lloyd, who is on the line to chime in as well. Preliminarily, the reaction to this question is really that we are seeing states allocate funding through various programs, some of which I've already mentioned, the ACO programs and other delivery system and payment reform efforts to invest in infrastructure that can support this work. Specific billable codes are being explored that cover this work. But I think that, we're early on in sort of having some really formalized coding that supports, some of these specific services being billable, although that does vary from state to state. I think the point here is that providers have, the areas of impact around this are, again, what I've mentioned earlier around measures that really relate to reducing ED and inpatient utilization that really translate into cost savings. And we recognize these are not the be-all, end-all and don't necessarily paint the full picture of what the benefits are of providing these services, but they happen to be the ones that folks seem to consider as somewhat of the low-hanging fruit in terms of being able to make the case for why, very limited resources at all levels are being dedicated to this work. FQHCs, I think, are more likely to see changes directly from health plans than from the states. And we've seen some health plans announce formally how they've been dedicating more and more funding to what we term social determinants of health, although it obviously varies in terms of focus on housing versus transportation versus food insecurity, United Healthcare being one that recently made that announcement. And those payments, that support happens through, oftentimes through grants, which obviously have their own issues in terms of sustainable support. So I think, I also did mention the disrupt activities that are going on in the state. And although some providers may not be directly part of those efforts, although most generally are, it's good to have awareness of the broader infrastructure that states are building to support that work. And it's challenging to just keep track of all of that, and we recognize that because we try to do that every day. But I think the point is tapping into where the states are already investing, because they all are to some degree. And while it may not equate to like a specific billable service, there are digital health platforms, there are other, staff extenders and other ways or investments that can really benefit the frontline providers in further supporting this work. So that's my preliminary reaction. Jim, I don't know if you want to add any more to that piece.
Yeah, I mean, I think that's pretty good, Deborah. Thank you for having me on the webinar. I think, yeah, trying to find some kind of alignment with another state effort, whether it's participating in some kind of payment reform or, leveraging your knowledge of a community through another state-funded program. And then also, a lot of these things to address social determinants of health, managed care organizations can invest in. And so while as a community health center, you might not be the one delivering those services, you could work to coordinate the delivery of those services with maybe an MCO that happens to be, interested in making those investments in your community. Those are my ideas.
Great. Thank you. Okay, so with that and not seeing anything in the chat box, I would love to turn to our discussants. First up, our Primary Care Association spotlights. So first up, I believe, is Nasha Chaudhry. Is that right? Go the lineup here.
Yes, that's correct. Thank you.
Great. Take it away.
So I'm just going to quickly share a little bit of information regarding our PCA before I talk about some of the work that we're doing around social determinants of health. So on the next slide, I have included MPCA's mission and vision. So the work that we do focuses around influencing the policy at state and national levels, while we're also serving as a voice for health centers and being able to provide them with support on our end on a local level. So as you can see, our vision is quality integrated care for all. So talking about our health centers, we have 45 health center organizations in Michigan, and that includes 38 health centers or 330 grantees. We have 3 lookalikes, 5 American Indian Health Service providers, with one of those providers also being a 330 grantee. And within Michigan, we're serving over 700,000 patients with over 300 sites throughout the state. So I'm sure most of you folks are aware that Michigan has an upper and lower peninsula. So if you take a look on the right side of the screen, you can see a breakdown of where our health centers are located throughout the state. I've included some text in terms of some of the work that our health centers are doing and the patients that we're serving. So if you read through some of this, you'll see 1 in 15 people living in Michigan depend on health centers for their services. Our health centers are focused on whole person, patient-centered care, and we're able to provide them with connection to social services throughout the communities. And the health centers focus a lot on ensuring that they're building these relationships within the community, and they're fostering resource sharing, which I always really encourage, because through the work that we do, it just makes sense for us to be able to utilize the resources that are already present within a community instead of reinventing the wheel a lot of times. With that being said, there's a quick summary on the next slide about who we serve. There's a breakdown in terms of the different types of services, and then a little bit of demographic information. So as you can see, in terms of patient income, about 69% of the patients served through the health centers fall below 100% federal poverty level, and then with 92% of them falling under 200. And then as stated in the bottom corner of the slide, there's insurance information as well. I'm just going to quickly mention a couple of the different things that we're doing within our state. So the conversation, of course, is around the Medicaid landscape, and some of that work has been done by former colleagues at the PCA in terms of our conversations and the work that they've done with MDHHS through the policy side and through negotiations of our memorandum of agreement. So one of the things that I always like to mention is the ability for us to be able to gain some additional dollars to supplement the wraparound payment that we receive from MDHHS. So we were able to incorporate outreach and transportation changes, and we were able to get $7.79 to be added to the visits, so every encounter rate that we were billing for. Some of the other conversations that we have continued with the state also include we are currently working with HMA to take a look at value-based payment, which is, of course, a very big topic for us on a national level as well. So we're working on focusing some of that work around addressing population health and having conversations around what we can do to incorporate some of that work into the new MOA that we will hopefully be sharing with the state. And then, of course, Michelle and some other folks are on the line who are part of the Prepare, Train the Trainer Academy. So we have taken part in the first round, and we are currently going through the second round as well. We have a handful of our health centers that are currently utilizing Prepare, doing a lot of work in terms of addressing SDOH, and then focusing a lot of their efforts in terms of providing that support to their patients, but also being able to track some of that through Azara. We've implemented Azara within 25 of our health centers, so we're able to pull a lot of that data. We're looking at risk stratification, and then just being able to provide that support in terms of connecting our health centers to resources and other funding opportunities. So we just continue to have that conversation, whether that's at with the C-suite staff or whether that's with direct care providers or other enabling services staff that are working within health centers. And we just continue to make the push for it because to us it makes sense. If you're addressing SDOH, you should be looking at enabling services data, and we're going to keep pushing for it. So we appreciate all the work that you do, and thank you for allowing me to be a part of this.
Great, thanks, Nasha. Wonderful. Turning it over to Angela.
Well, good afternoon. I'm Angela Herman-Nestor with the Missouri Primary Care Association. So I took a little a picture of Missouri landscape. We do have 29 health center grantees in Missouri that are located in urban, suburban, and rural communities across 114 counties in the city of St. Louis. And it's important to note that Missouri was not a Medicaid expansion state. So in 2017, we were the medical home for 565,000 patients with over 2.4 million encounters, and about 46% of the patients served had Medicaid. 26% were uninsured. We had about 19% private and 9% Medicare. So that kind of gives you a sense of our payer mix. So we've been on the journey working on social determinants of health, Prepare, and community health worker efforts. Really strong efforts started in 2015 when our health center board of directors made it a strategic priority to focus on population health, the value-based care, social determinants of health, and they also decided that Prepare was going to be the tool that we would utilize in Missouri. In 2015, our state Medicaid began a pilot for using community health workers to address the social determinants of health needs of high utilizers of the emergency room for patients that were part of our Section 2703 health homework in Missouri. And so that pilot included not only some of the health centers, but also some of the hospital-based clinics that were participating in our health home. And that work had some real promise. And because of that, in 2016, our board voted to leverage some state general revenue dollars that health centers receive to pull in a federal match to establish our community health worker program. And that funding was appropriated during our 2016 legislative session. And that received bipartisan support, which in Missouri, we've had several very tough budget years, I'm sure, unlike most states in the country, but we still received that bipartisan support, and so that was really wonderful. And so we started some of our training and education with NAC as well as Siouxland Health Center in Iowa to start to lay the groundwork and provide the training for our health centers. Next slide. In 2017 is when we really began implementation of our community health worker program. Like I said, we utilize the PREPARE tool to assess the social determinants of health. And we partnered with NAC and the Michigan Primary Care Association to provide some training and technical assistance. One thing that we also did with the funding initially was we partnered with the University of Missouri to develop and launch a community health worker ECHO. And that ECHO is well attended and provides a forum for the community health workers to receive training, discuss cases on tough social determinants of health needs in the communities that they serve. And so that has been a wonderful forum for us in Missouri. We also utilize Azara Drives for our population health management tool in Missouri. So we have partnered to add the social determinants of health functionality so that the health centers can begin to utilize that information, and we can also utilize it for our policy and advocacy work that we're doing in the state. In 2018, we established a community health worker peer learning network of the community health workers working in health centers across the state. And we also decided to really kind of up our game a little bit to start enhancing our reporting for the social determinants of health information. And we include that in our contract, and we report that to our state Medicaid agency through those contracts. Our state, we also partner with our state Department of Health and Senior Services. They have a statewide advisory board that the PCA is part of, as well as many other organizations. And Missouri is moving forward with creating a community health worker credential, which will be very similar to our, on the mental health side, a peer support specialist. So we're really excited with that, and our Medicaid agency will require that credential moving forward if we get to the point where we're able to do reimbursement. And we've also just established in Missouri a Community Health Worker Association. Next slide. So we are working and partnering with our Medicaid MCOs, as well as our state health department, our Medicaid agency, to really start to look at how can we address the social determinants of health of patients and support a community health worker workforce sustainability. So there is a formal committee that has been meeting to try to work on these issues and also provide some insight into our Medicaid agency as they start to look at reimbursement for community health worker services. And our Medicaid agency had planned to move forward in Missouri. They were going to pursue a state plan amendment to allow reimbursement of the community health worker services. However, unfortunately, they didn't receive full gubernatorial support to move forward this legislative session that started in January. But some of the work of the Sustainability Committee, we put together some talking points. So we did have some state legislators that really took up the cause for community health workers and the importance of addressing social determinants of health needs. So one of the things that's working through the legislative session right now is a proposal to add more funding to our community health worker program for health centers. It doesn't get us to where it's reimbursement for community health worker services, but for our health centers, it could allow them to expand to add additional community health workers and be able to support more patients. One of the things we're also doing in Missouri, we are starting to look at value-based payment. Our Medicaid agency is moving fast down that track, and they really see health centers as being an important part, and we view community health workers as being an integral part of that as well, because we know addressing and helping patients meet their social determinants of health needs has a major impact on engagement of the patient with the health center, getting to come in so we can close those care gaps that can result in real money for the health center. So we really see the community health worker as being a very important part. For future plans, we hope to be able to incorporate social determinants of health risk into our risk algorithm and assignment of patients, because we think that that's going to be critical as we move into the value-based payment, that it not be just based on cost, which is oftentimes what the MCOs do, is it's based on cost, but we'd like to see some of the social risk incorporated. We also hope to incorporate some of the encounter information of what those community health workers are doing with patients into some of our structured documentation. And also we hope to track some cohorts of patients to see how their social determinants of health needs and achievement have really helped with the quadruple aim. So that's all I have.
Great. Thank you so much, Angela. And I really appreciate the breadth of experience that you all brought to bear. And I'm feeling a little less offended because I put out a call for some information in the chat box and I didn't get any responses, and it's because I think we're having a problem with the chat box. So to those of you out there who are trying to post questions, I think we're having some technical issues there. We can certainly unmute you. But I also wanted to remind participants that we're fortunately going to be joined by Angela and Nasha next week, also with Nasha's colleague, Julie Tatko, formerly of Michigan PCA and currently at Cherry Health, just to again get a little more granular, because we've gotten some really wonderful big picture themes and frameworks, et cetera. So looks like the chat has opened up. At least I got one from Marcella. So I think what we're going to do in this chat vacuum, as it were, is we luckily have the questions that you all submitted. And so I'm going to start to call those out. I do know that I think some of our panel members have to hop off. But I'm going to call them out and would love to hear from anyone of our panelists and also from our providers, because if you can't get in the chat room, you can at least unmute yourself. So here's a question that I'm going to put out to the audience from North Carolina, which is, I live and work in North Carolina as a state that's moving into Medicaid managed care this year. And next, how can I prepare for the coming change? And how do I guide the health center I work in to understand the importance of SDOH to improve health outcomes? So that's a pretty open-ended question. I think we've gotten some insights from the presenters, but I don't know if anybody wants to tackle any aspect of that.
This is Michelle Jesser from NAC. Can you guys hear me, or am I?
Yep, we can hear you.
Oh, okay, great.
Thanks, Michelle.
Yeah, that's a great question. I think it's really helpful, depending on the audience, that you really frame how social determinants of health can really help your organization better achieve the goals of the quadruple aim. And a lot of that comes down to population health management, that if you're able to have data on your social determinants, you could better segment your population such that, let's say you X amount of your patients are diabetics. Then you could segment that population further to say which ones are uncontrolled diabetics. And then when you overlay social determinants of health data onto that, you can then see how many of your uncontrolled diabetics are having transportation issues or they're having food insecurity. And I think having a visual or having those kinds of stories at your palm of your hand can really help the staff at a health center, regardless of if they're a clinician or a non-clinical staff. I think that just really helps them visualize how this data can really be used to provide better care for their patients. And then when I was mentioning the quadruple aim, so that's obviously one with outcomes. If you're better managing your population, hopefully that's ultimately leading to lower total cost of care. We've heard from a lot of health centers that are using Prepare that providers are very excited about it because it allows them to really provide better care, and they can actually focus on the clinical outcomes if social determinants are taken into account in other parts of the clinic. And then patients actually really appreciate being asked, and they appreciate being viewed as a whole person. So again, just kind of ticking off all the quadruple aims. And then also just from a business case standpoint that if your organization is starting out with social determinants in your state, you guys will be leaders in your state and you will be better prepared to engage in value-based pay, in managed care, all of those things because, and what was interesting in North Carolina, it's interesting you bring that up, that I think because so many of the health centers in North Carolina were using Prepare, you guys in your PCA had that data to then be able to share with the Medicaid agency and with the Blue Shield of North Carolina Foundation to show, here's what we're seeing, here's how complex our patients are, and so this is why we need these different things, or this is why it's important to include social determinants in the waiver. So I think, having that data allows you to do a lot of different things and really sets you up to be leaders in your state.
Great. Thanks, Michelle. Any other comments from our faculty?
I put a link, just because of North Carolina question, put a link to North Carolina's Healthy Opportunity Pilot. That's the 1115 waiver project. My understanding of that is that some of the large-scale health systems are really seen as the lead. They've got sort of, shall we say, the biggest tables in order to bring everybody there. But different communities are going to have different, different places where they come together. Some places it's where, where that intersection happens. Some places it is around data. Is your community have a health information exchange, or are they building one? That's where you can pull some of that information. There's conversations happening in communities about how they're pulling that data and what information there is. I would say that most commonly, every time, you do a first data pull of some of that, you'll see things you didn't expect, and you'll also see things that really make you question and really drill down more into that data and highlight how important that is, highlight how important there is those conversations between the intersection of the clinicians in your team and the data folks, if you've got those, or if you're, contracting out with a university or something to bring those mixes together. Everybody, brings a slightly different lens to the activity from their background. And so you really want a mix of people to be looking at that information that Michelle talked about putting together and, being able to take forward and really being able to, again, both tell the story, and some of your audiences are going to respond to, the numbers and the health cost savings. Some of your audience is going to respond to improved health outcomes or how you've been able to address health equity in your work. And then some people are going to respond to just, just basic stories, the story of a community health worker, the story of, some of your patients, et cetera, and thinking about having all of those different kinds of stories in your back pocket, all of those different ways to make your case in your back pocket, and then know your audience and know what your audience responds to, I think is just really important. So, hitting on multiple levels here.
Thanks, Marcella. I'm going to go to a more operational focused question that we got from Healing Hands Ministries in Texas, which is when building up a team of staff members from primary care health center standpoint, who is often included when addressing SDOH initiatives? I have ideas of how many different health professional staff, admin, et cetera, can add insight to these initiatives, but how do other health centers use their staff resources? So maybe our PCAs you talked a little bit about that, particularly in Missouri, about the community health worker role, but if you have thoughts or reflections on that.
Yeah, this is Angela. So certainly the community health worker has been an integral part for us, being the one to administer the prepare with patients and then working with patients to prioritize what, with the social determinants of health needs that are identified, what needs they would like to work on, and then helping them find places to address those needs. So certainly a community health worker alone cannot do this work. So we found that having that partnership with other members of the care team, in particular the nurse care manager and behavioral health consultant, has worked really well for the community health worker to receive those referrals from those folks, but also if they're out in the home and when they come back, they provide that information. So they're kind of the eyes and ears for the care team out in the home and in the community with patients. So that can be extremely helpful. And having provider buy-in so that the providers view the community health worker as an important part of the team. And this work really does take that team-based approach, is what we found in Missouri.
And this is Nasha. I'd just like to add on to it. A lot of the work that MPCA is doing in terms of providing that support to care teams also includes several of my colleagues here at the PCA providing support not only to community health centers, but also continuing that conversation with other folks around the table. So we work directly with the Michigan Community Health Workers Alliance, and we're actually going to be advocating for CHWs next week. You know, the conversation has always been, is there a way to possibly get CHWs reimbursed? And I'm sure Missouri is also having that same conversation. Even if we aren't able to reimburse them, are there ways to create specialty CHWs who specialize in different areas so we're able to incorporate them into care teams that are focusing on specific projects? And that's been a conversation also on our end because we have several different programs that we rolled out to our health centers that we are working with them on, where we have different members of the care team, including CHWs, providing that support. And so being able to, as I mentioned, continue to have that conversation. One of the programs that we're currently working on is the My Care Team, and that's working to address the different facets of the Medicaid beneficiaries' health status. So we're looking at not only clinical needs, but we're also focusing on social determinants of health. And so the model is created to be able to support patients in self-management of chronic conditions, and then, of course, thinking long-term in terms of reducing healthcare costs, and, of course, ultimately raising the quality of life for the beneficiaries that are participating in it. So we have a couple of different programs that we're trying to incorporate into our care team model. Of course, you know, with the substance abuse disorder work that some of our health centers are doing, we have peer recovery coaches who are able to have these conversations and address some of the social determinants of health. And then, of course, we want to make sure that the team is robust enough that we have folks who are able to provide support and also connect them to these resources that they're in need of, right? Because if we just have these social determinants of health and we're getting all this data, but we're not able to connect them to the resources and provide them with access to it, then it defeats the purpose of the work that we're doing.
Great, thanks, Nasha. Great. Well, I just wanted to call out, we have a couple of questions in the chat box and a couple of misfires that I did. We had somebody who's looking to get in touch with Angela. So Angela, okay if we share your contact info? So we're looking for a follow-up.
And
Great.
I'll also be providing more detail next week on our, on our program. Yep. So I might be able to answer some of those next week.
Yeah, thank you for that reminder. And I think that's really good for folks, participants, now that the chat box is wide open and you can be thinking ahead, and some of this information will be marinating about how to prep your questions and reflections for the session next week, which will be very much a kind of concrete strategies and try to meet you where you're at. I have some more questions I'm happy to call out so that we can keep the conversation going. So let me do this from Louisiana, which is, in states that do not have large integrated health systems, how does one bring together the various healthcare silos with the goal of getting key stakeholders like MCOs, public health, healthcare providers to the table to plan and share data and strategies to address SDOH? And I heard these themes from all of the speakers who've shared, but this is another opportunity to maybe take a gem that you might have as a faculty member to share with our participant from Louisiana, Millie. About how to go about engineering some of these convenings that are really important to doing this work, if people have thoughts on that.
Just, Marcella, a couple ideas I've seen. One, connecting with local philanthropy. Most health centers have, grants from different, local or national related health foundations. They're often putting together a table we're seeing lots of tables at CSH around health and housing, but you may want to be focused on another SDOH. And a lot of times, when they send that invite out, because people are expecting this is going to have an impact on their funding and on their, donations and giving, that they're going to, that they'll get a lot of people there. The second I would say is to look at what's happening in your community, or join or convene a roundtable around a particular community health-related issue. So maternal mortality, childhood asthma, just two examples where we've seen that the diverse stakeholders that's going to need to address that issue is something that's being, raised up, and those tables are there. Clearly, health centers and PCAs have to be at that table and have to both share what they're doing is also as a way to bring that kind of cross-sector work. And then the third example is think about what are some health-related priorities of some of your local political leadership, if they have them. Is there any alignment with what they're trying to do in the healthcare-related space? And they convene the stakeholders. They're always looking for opportunities to hear from their constituents, to hear what's happening in their communities. And that's another place where you can both raise up the issues, find allies, and if maybe that local leadership or some of their staff were able to kind of keep that conversation going and the groups there around a particular issue that they might have gelled on. I think that's another place where you can, find your allies and build your case. Do the organizing that's necessary to make some of these changes. Just some thoughts.
Thanks, Marcella. Other thoughts from faculty or participants around convening? Very powerful tool.
This is Nashia. One of the things that I really want to mention that I think the Michigan PCA does very well is always keep those lines of communication open with not only the state agency, but, the health plans and other folks that you would want to bring to the table when you're having these discussions. We've always made sure that if there are issues that our health centers would want us to get involved with, that we make others aware that we would want to be at that table and include the health centers as part of the discussion, because at the end of the day, we're seeing a significant portion of the Medicaid population, and the health plans are aware of that, and they also need to be aware of the fact that the work that we're doing is also supplementing a lot of the different initiatives that they're working on as well. And just being open to the idea that although a lot of the work that we're doing is not currently billable or reimbursable, just continue to have those conversations. I've been in communication with a couple of people at the state just to talk about what are possible ways that even if it's not possible for us to bill for the work that we're doing right now, are there other ways that we can discuss maybe possible changes in the future where we can support the work that the health centers are doing. But a lot of our health centers focus on the grant funding that they're receiving in terms of the different programs that they're cooperating in, and being able to tie some of the work that they're doing with social determinants of health into the grants that they're writing for. So, Julie will be on the call next week, but she can talk more to this. But Cherry Health has this unique way of, tying the work that they're doing for medical legal partnerships into some of the other grants by proving that justification that, their legal aid partners are able to support the work that they're doing around SDOH. So just being open to the idea that you may not necessarily need to focus on specific grants to get money to support a certain project, but being able to tie certain aspects of the work that you're doing into other grants and being able to justify that within your grant proposal will allow you to diversify some of that revenue and some of that grant funding that you're receiving.
I would like to second that. This is Angela. Is looking for ways that if you have a specific chronic disease funding that you're working on, what are some ways that you can incorporate social determinants of health into that work? We have found that our state health department has been very agreeable to that with our diabetes and cardiovascular work that we're doing, as well as some of our cancer prevention work. So that is an idea. The other thing is when you're starting to have conversations, certainly at your local and regional level, but also look to see if there are other health centers in your state that are also interested in this work. And there is a lot to be said that having a group so that you're not having to go to the plans or to others by yourself, that can be a very good strategy, is to look to see what is going on currently in your state and see if there's some other health centers that you could partner with. But certainly your local organizations in smaller, more rural areas, a lot of times the faith-based community is a very important community to partner with. They're also oftentimes helping with some of the food insecurity and things like that. And we've also started having some of our regional food pantries are starting to do where they're bringing mobile markets or mobile pantries into our rural communities. So that's something that we're starting to see so that we can address the food insecurity in some of our more rural areas. So that would be an encouragement I would have, is look to see what your local partners are, and even some of those non-traditional, not necessarily healthcare partners, but really coming to the table to see how you can better serve the individuals that live in your community.
Great. Thanks, Angela. So I have a question for our faculty because this work clearly, and what we've heard from each of you, is, you got to be creative, you got to be flexible, you've got to be intuitive, you've got to take your vitamins because it might take a while. And I would love if anyone has a cogent story about a bump in the road that they want to warn everybody else about, or some third rail that they might have hit, not to be a Debbie Downer, but instead to, remind folks that it's not all sweetness and light as we pursue innovation and change. So that might help us think about, what are some of our concrete strategies we want to make sure we have on board. Anybody want to volunteer for that? You can take a think minute. Maybe not. Okay, I'm going to go back to some of our questions. You guys can continue to think about it, but this is a little bit along those lines. From somebody in North Carolina again, how do you continue to meet SDOH with limited resources in your area? And again, I think, you know, faculty have hit on some of these questions, but, you know, if you have other thoughts. Yeah, go ahead.
This is Michelle from NAC. We've actually heard some really interesting stories from a couple of different states where there would be a health center in a rural community, so they really didn't have a lot of resources to be able to respond. But because they had that data to show the need in their community, they were able to share that data with food banks, with housing agencies, with, you know, all these different types of organizations that were located in the next big city that was closest to their rural community. And by having this data, they were able to make the case to these organizations that it is worth bringing resources to this community. So one in particular is that there was a health center in a rural part of Massachusetts that they had a huge food insecurity need, but they had no food banks in their community. So they reached out to a food bank that was based in Boston, which was 70 miles away. So again, not just down the street, but 70 miles away. And because they had that data to demonstrate the big need for fresh fruit and vegetables and other, you know, non-perishable goods, the food bank now does a weekly delivery of all of those items to this community at that health center. And because of the data, they were able to demonstrate that it was worth the partnership and the travel to do so.
Great, thanks for that, Michelle. Other thoughts or comments? Great, should we keep going? I want to make sure I'm current with the chat box if we have anything coming in. And just a reminder, I put it in the chat box, but for those of you who might not be up to speed there, we have an intrepid volunteer for next week, Kick the Tires session with our faculty from Missouri and Michigan. And we're looking for a 101 and a 201 participant. So folks were kind of spread across those three levels of skill or engagement. And so if you clicked 101 when you took the poll, think about whether you want to volunteer with us to share where you're at, what you're doing, and we'd love to hear and be helpful if we can next week in next week's session, so you can offline with us. Great. And let's go to one more question. I know we had a question from our friends in Texas that was for our ACAP faculty. I don't know if you want to tackle that question, Deborah, if you're still on. I think you might have had to step off, but
I'm on.
I'll put it out there.
I'm on.
Oh, you're great. Great. If you want to tackle that question too. Yeah.
Yeah. Yeah, unfortunately, we don't have the tables published in a way. I think the question was, can you pull the details by state specifically across the board?
That's
and
right.
We didn't model it that way. So I think the best way to do that is just to refer to the endnotes for the particular row in the table that you're interested in, and that's where you can see kind of the sources. But unfortunately, we don't have it compiled that way by state.
Okay, great. We also had another question about, we've heard a lot about Prepare and its value, but we know there are other tools for conducting assessments, and I think they've been referenced. So if there are other suggestions of models or tools for doing SDOH assessments, then that was a question that came from Tiffany in California. And so if folks have responses or suggestions or links they want to post in chat, that would be great.
Yeah, this is Deborah. I'm sure others have other examples. We've done a couple of summaries of some of the kind of leading tools that we've seen in use based on some provider-facing projects. So you all naturally may be aware of others, but one that I think additional to the Prepare Naturally, the Accountable Health Communities tool is one that we've seen because we are providing technical assistance for that model. And I imagine some of you may be familiar with that, given that there are providers within your respective states that are participating in that model. There's a couple of others we've seen, one out of Access Health Spartanburg, a social determinants of health screening tool. There's a couple of other health assessment tools. So I won't ramble off and list all of them. There's a Health Leads one as well. Rather, I can send along to you to share with the group just a couple of write-ups we have around, the relative functionality of these tools, or not so much the functionality, but what they're each asking about, because they each have some slightly different focus in terms of the questions and structure. And at the end of the day, I think we've heard from providers, and you all have reiterated already, that the data, really what you're screening for is really around where you can provide the service, and how you're going to use the data sort of feeds back into what you're screening for. So the questions vary as a result in terms of the types of services you are able to link to, and also just the types of data you each feel are the most important to capture, recognizing limitations on being able to capture everything. So again, I'm happy to share that. I think Siren also has a compare tool.
That's right.
Actually, Deborah, this is Michelle Jesser with NAC. I would actually caution health centers to look into the Accountable Health Communities tool. If you're already in the demonstration, obviously you have to use it, but we've heard from a lot of health centers that have actually pulled out of the demonstration program because the questions really lack sensitivity. Like for example, there are questions on like how many times has your partner hit you? And the Accountable Health Communities has a really strict method for administering this, that you have to ask the question verbatim, word for word. That questionnaire is not built into the electronic health record, and so you have to fill it out on paper. And so we don't think that data is very actionable. So I would actually kind of caution health centers against the Accountable Health Community tools, just because of what we've heard from the field from other health centers that had to use it for the demonstration program. And also, we've actually heard from CMS that they view the Accountable Health Communities as just a demonstration project, and that they expect it to go away once the demonstration project ends. And so, again, I would hate for health centers to start using a tool that then may not be supported by CMS later. ONC is actually very interested in Prepare as a tool to use across states for interoperability, because it has been tested and vetted and validated. And I guess I do have a bias, obviously, but I think just from a health center movement perspective, the more that we have health centers collecting the same standardized data on social determinants of health, the more that we can make the case around how health centers' patients are different. Therefore, they need different services. What do you know? Health centers actually already provide a lot of these services and a lot of the enabling services. However, they don't get reimbursed for those services, and therefore that allows us to make a policy and advocacy case to help find more policy and payment systems that actually sustain and support upstream work. So sorry to interject there, Deborah, but I just kind of wanted to make that.
I appreciate that completely, and I agree that has been the sentiment around the HC tool. We are quite neutral particularly around this. I'm not suggesting anyone is better than the other. So I think, though, from an awareness perspective, it's helpful for folks to know what this tool is and how it's being used, because it is being used, as you've noted, among some of the relative providers who some of you may be partnering with. So I'm just talking from an awareness perspective that this is the landscape of the tools. And beyond that, we will not comment about which is better than other. So defer to you on that front. So I appreciate that.
Thank you, guys. And I'm hopping in here because we're hitting time, and really, I think a very, very helpful discussion, right, about the dynamics of screening tools and other types of tools, and really setting the stage for next week, when we're going to get, again, into the weeds a little bit with some of the participants and also our faculty, expert faculty joining us. Do I have any more slides I need to run through, Janice? Can you ping pong ahead? And while we do that, maybe a virtual round of applause for our fabulous faculty. Deborah and Jim, really appreciate all of your work. Oh, there's my call out. I'm looking for people who want to volunteer to get their tires kicked. And I'll be pinging you on Slack, looking for volunteers. We've got our HRSA acknowledgement, of course. And please, oh, please fill out our survey and let us know how we're doing, because we want to know from you. And so that is our time. Really great appreciation for our faculty again, really setting a great stage for us. Sorry if I trundled in there and cut Michelle and Deborah off, but there you have it. We're going to have lots to talk about and lots of different opinions and perspectives, and look forward to diving in with folks a week from today. And again, thanks to Deborah and Jim. And Nasha and Angela, we'll see you next week. Thanks, everybody.
Thank you.
Okay,
Thanks, everybody.
Signing off. Thank you.